we are going to discuss a very important oral hypoglycemic agent, dipeptidyl peptidase 4 inhibitors, informally also known as gliptins. As we have discussed in the previous video about incretins like glucagon-like peptide 1, these are released from the gut in response to the glucose. Whenever we will take food, the intestine releases some incretins like GLP-1 and GIP, and these acts on the pancreas and they stimulate the release of insulin while inhibit the release of glucagon. If they stimulate the release of insulin, they will decrease the blood glucose, and by inhibiting the glucagon also they decrease the blood glucose. How? Insulin क्या करेगा? It will increase the glucose uptake by the peripheral tissue. और glucagon कम होने से क्या होगा? जो hepatic gluconeogenesis या फिर glycogenolysis कम होगा, तो hepatic glucose production will be less. Okay. So therefore blood glucose level will be reduced. Okay, now the problem is with these incretins, what is the problem is that these are metabolized very rapidly by an enzyme dipeptidyl peptidase 4 and they're converted into inactivated version. So these are very short acting. So what we can do is we can inhibit this enzyme. Dipeptidyl peptidase 4 causes the rapid degradation of endogenous GLP-1. Now we have prepared some orally active dipeptidyl peptidase 4 inhibitors, and these can inhibit this. If this can be inhibited, then this will remain activated and the insulin will keep on releasing. So they are also known as indirectly acting insulin secretagogues. So they causes the release of insulin, and these are indirectly acting. Okay. So this is, if we see this is the beta cells and these are the incretin receptors. Okay, the GLP or GIP, when act on these receptors, these are G protein coupled receptors. So they stimulate the adenyl cyclase. Adenylyl cyclase enzyme will convert ATP into cyclic AMP, and cyclic AMP will stimulate the insulin exocytosis. Okay, now these incretins are inactivated by this enzyme into inactive peptide. Now the gliptins can inhibit this enzyme, so this is how it acts. This will cause the insulin release indirectly. Now Dpp4 inhibitors, these are orally active. First very important thing, because Glp-1 analogues we have seen, they are not orally active and they are given by subcutaneous injection. So first advantage are these are orally actives, and what are they? We have discussed indirectly acting insulin secretagogues. Now the very advantage with them is there is less risk of hypoglycemia with them. Okay, and about body weight, they are body weight neutral or may decrease body weight loss करेंगे, or they will be neutral. And they are contraindicated in type 1 diabetes mellitus. Why? Because they're indirectly acting agents. Okay, so beta cell function is required, and also they're contraindicated in pregnancy and lactation. They have some extra glycemic actions, like they decrease the total cholesterol level and decrease the triglyceride levels also. Okay, as a whole, the group has some rare side effects, that is pancreatitis and bullous pemphigoid. These are the side effects of the whole group. Okay, pancreatitis and bullous pemphigoid. Now let us see the drugs one by one. The first one to discuss, let us discuss with Sitagliptin. Sitagliptin, it is a competitive and selective DPP4 inhibitor. ठीक है, तो कॉम्पिटिटिवली एंड सेलेक्टिवली खाली DPP4 एंजाइम को इनहिबिट करेगा, तो इससे जो पोटेंशिएट कर देगा इंक्रेटिन एक्शन GLP-1 GIP का, एज वी हैव सीन. Then what will happen? The insulin will be released and glucagon will be decreased. So it boosts the postprandial insulin release and decreases glucagon secretion. So it will decrease the fasting as well as mealtime glycemia in type 2 diabetes mellitus. Now the GLP-1 analogues, they were also acting on the GLP-1 receptors on the intestine, and they were affecting the gastric emptying and appetite. But this is not affecting, there is no effect on gastric emptying and appetite. Body weight, it is body weight neutral or may cause weight loss. And there is low risk of hypoglycemia. HbA1c lowering capacity is similar to that of a metformin. Now, they could be used as an adjuvant drug in type 2 diabetes mellitus, which is not controlled by metformin, sulfonylurea, and pioglitazone combinations. They can also be used as monotherapy when metformin cannot be used. Dose reduction is required in renal impairment, but not in liver diseases, because largely excreted unchanged in urine only. What are the side effects? It causes nausea, GI side effect, loose stools, headache, rash, allergic reaction, edema. Okay. Then it causes Now, what are the side effects? There are some rare side effects of the sitagliptins. Nasopharyngitis and cough and flu and pancreatitis is a rare side effect. Now, the cardiovascular outcome trials with sitagliptin, the name of the trial is TCOS. TCOS trial of sitagliptin has confirmed that it has cardiovascular safety profile. Okay. So this is all about sitagliptin. The next one is vildagliptin. Vildagliptin binds to the enzyme dipeptidyl peptidase 4 covalently. Okay. And the complex that is created, it dissociates slowly and resulting in a persistent DPP4 inhibition. Okay. That is why despite having a shorter T half, it has a longer duration of action. The major route of elimination is the hepatic metabolism. Only 20 to 25% is eliminated, excreted unchanged in urine. So the dose reduction here is required in both liver diseases as well as kidney diseases. Okay. Now vildagliptin के साथ क्या है, एक तो मैकेनिज्म थोड़ा डिफरेंट है कि कोवलेंटली बाइंड कर रहा है, सीटाग्लिप्टिन से ये डिफरेंट है, सीटाग्लिप्टिन वाज इनहिबिट कर रहा था. दूसरा क्या है, vildagliptin लेस सेलेक्टिव है देन सीटाग्लिप्टिन फॉर DPP4. इट आल्सो कॉज इनहिबिशन ऑफ DPP8 and DPP9. So the clinical significance of that is not known, and the side effect is hepatotoxicity. Okay, बिकॉज इसका मेजर मेटाबॉलिज्म हेपेटिक मेटाबॉलिज्म है, उसके अंदर हेपेटोटॉक्सिसिटी सीटाग्लिप्टिन में नहीं था. वाई? बिकॉज इसका मेजर मेटाबॉलिज्म वाज थ्रू रीनल मेटाबॉलिज्म था. Now, there are two more drugs, sitagliptin and linagliptin. Sitagliptin में it is contraindicated in heart failure. ये भी CVOT trials के अंदर पाया गया है. इसका मैकेनिज्म सेम विल्डा जैसा है, कोवलेंटली बाइंड करते हैं DPP4 से, तो फिर वही शॉर्ट टी हाफ होने के बावजूद भी लॉन्गर एक्टिंग होगा. Linagliptin में there is one difference that 90% excreted unchanged in feces. We have to remember all the gliptins are excreted in urine except the linagliptin. Okay, linagliptin is excreted unchanged in feces. Okay. Now the therapeutic status as per American Diabetes Association, in a type 2 diabetes mellitus patient, first line is metformin. If the atherosclerotic cardiovascular disease or CKD is present, then second line is SGLT2 inhibitor or GLP-1 receptor agonist. Then third line could be DPP4 inhibitors. Okay. Now if there is no atherosclerotic cardiovascular disease or CKD, and the aim is to minimize the risk of hypoglycemia, then second line mein we can give DPP4 inhibitors or SGLT2 or others. The DPP4 inhibitors here could be a second line. When the aim is weight loss, then SGLT2 inhibitors or GLP-1 receptor agonist is second line, and then third line could be DPP4 inhibitors, and DPP4 inhibitors only if SGLT2 inhibitors के साथ combination में दे सकते हैं, not with GLP-1 receptor agonist. Okay, we have to note this that DPP4 inhibitor and GLP-1 receptor agonist combinations is avoided. Okay, it is avoided. Why it is avoided? Just because there is no added benefit seen. Okay, now if the cost is an important factor, then sulfonylurea second line, third line is thiazole, dindion, and the fourth line will be DPP4 inhibitors here. Okay, so DPP4 inhibitors अगर atherosclerotic cardiovascular disease present है तो थर्ड लाइन है, अगर नहीं प्रेजेंट है और हाइपोग्लाइसीमिया को बचाना, रिस्क को कम करना एम है तो सेकंड लाइन है. अदरवाइज वेट लॉस एम है तो फिर ये थर्ड लाइन है, और कॉस्ट इंपॉर्टेंट फैक्टर है तो ये फोर्थ लाइन है. ठीक है, और दिस इज ऑल अबाउट डाइपेप्टिडाइल पेप्टिडेज 4 इनहिबिटर. थैंक यू.